Hi, this is Rachel from I Need IVF, and today I'm going to have a little chat with you about fertility testing for women. So this is kind of the initial fertility testing that you might go through once you've presented to your GP. So first things first, when should you actually go to your GP if you're trying to conceive and have not been successful? So the NICE guidance, NICE is the National Institute for Health and Care Excellence, suggests that for women under the age of 35, you should be trying for 12 months before you approach your GP. And for those ladies over 35, you should approach your GP after 6 months of trying unsuccessfully. Now, why is there this discrepancy between below and above 35? At the age of 35, unfortunately, ladies' fertility does tend to decline. So what they're trying to do by suggesting only 6 months for ladies over 35 is trying to get you help as soon as possible, because it is more likely that you're going to have problems trying to conceive at this point, and time is of the essence, because the further on you get and the older that you get, the more your fertility unfortunately will decline. So this is kind of the reason why there's slightly different recommendations for ladies under 35 versus over 35. Now, depending on your NHS trust, you will either be kind of referred to a fertility clinic or a gynecologist, and this process isn't always quick. It could take up to 3 months, and for this reason, occasionally some GPs will actually start the kind of testing process themselves, but it is more likely that they'll want to send you to a specialist of some kind, because their interpretation of the results might not be as good as somebody who specialises in kind of fertility. So me and Nathan both went to our GP. I was referred to our local fertility clinic at our local hospital, and Nathan was referred to a separate local hospital which did the sperm dialysis. However, I had an initial appointment with the fertility clinic, and Nathan attended this with me because it's important that both partners are there. And this initial appointment was with a specialist nurse, a fertility specialist nurse, who essentially went through all the basic things you would expect them to. So she discussed whether I had any history of pregnancy, which I didn't, so that was a really quick discussion, but she will go through any miscarriages you may have had. I say she, it could be a he, but it's more likely to be a she. It could also be with a doctor, it really just depends on your clinic. She went through my cycle history, so the average length, whether I particularly got any pain, how heavy my bleeding was, all of these kind of things, looking for kind of any suggestion that I could have like excessive pain, which might indicate something like endometriosis, or if my cycle's particularly irregular, that could kind of suggest polycystic ovarian syndrome. So kind of went through all of that. She then went through both myself and Nathan's sexual history, so how long we've been trying to get pregnant, how many times a week we were having sex, whether either of us had any history of STDs that might impact our fertility. And then we went through medical history in general, so kind of chronic conditions, and particularly anything relating to the pelvic area. So for me, I have previously had a cervical biopsy, which kind of came from one of my smear tests. So we just kind of briefly discussed that. But nothing came up really that made her think that there was anything that stood out that should affect fertility for us. She then kind of went into lifestyle questions about smoking, alcohol, exercise, and did a weight and height on both of us, and basically gave the advice that you would expect. So kind of advice on stopping smoking. Nathan was a smoker. Alcohol intake, neither of us are particularly drinkers, and to be honest, I drink maybe once a year and have like a pint, so that wasn't really appropriate for either of us. Exercise, so the usual kind of recommendations on exercise, 30 minutes, I think it is 5 times a week, of moderate to high intensity, and then a weight and a height. So when she did that, she then calculated BMI. Now, BMI is important because there is evidence that unfortunately obesity or being underweight can affect your fertility. So the normal range for BMI, I think, is 18.5 to 24.9. I actually sit in the slightly overweight category. My BMI is usually somewhere between 27 and 28. But generally speaking, they don't particularly worry unless your BMI is above 30. So 30 is also one of the cut-offs that is often found for kind of assisted reproductive technologies as well. So for IVF, often clinics won't treat you unless you can get your BMI to 30 or below. All these little bits are discussed, but again, there was nothing really that crept up that made her think that there was anything in particular they should be looking at. So from all of these discussions, essentially then she made recommendations for the kind of fertility tests that we needed to have done. Nathan was already booked in for his sperm analysis, and so they just asked him to bring his results from that to the next appointment that we would have, which would then be with one of the doctors. But in the meantime, I was sent away with a list of tests that I needed to get done. The first things they really did for me were blood work, and I think this will probably be where most ladies will start. So essentially they're looking with the blood work to see if there are any kind of hormonal imbalances that could affect your cycle in any way. Mostly ovulation, but also looking kind of to ovarian reserve. The first one that I'll hit upon is follicular stimulating hormone, FSH. This is usually done on day 2 to 4 of your cycle, and it's basically a good predictor of ovarian reserve. So the normal ranges for this do vary depending on your age, but a higher result unfortunately means the greater kind of impact on your ovarian reserve. So as general, anything above kind of 12 indicates some kind of impaired ovarian reserve, and above 25 is usually associated with ovarian failure and with early menopause, depending on your age. But like I said, it's all very age related, so these are kind of a general normal range, but please don't take them as the Bible, because very specific. Now, at the same time as you have that one, you'll probably do most of your other tests, depending on kind of when your clinic want them done. So other ones you might have done are luteinizing hormone. This has different normal ranges depending on the stage of your cycle you're in. So the follicular stage, which is the stage kind of from your period up until the point where you ovulate, is they would expect your LH to be somewhere between 3.3 and 11.3. At ovulation, they would expect it to be 17.8 to 111. And during your luteal phase, which is post-ovulation and before your period comes, they'd expect it to be somewhere between 1.1 and 13.4. Now, it's important to note here that all of these normal ranges are for the UK and therefore shouldn't be applied to the US because we use different units. So just be aware of that. So it is important that if you are from the US or another country, you do look up the normal ranges for your country because they will be slightly different. So essentially, what are we looking at with luteinizing hormone? It's quite complex in its interactions, and it's really closely linked to FSH and progesterone. And essentially, it's used to help grow and maturate your follicles. But high levels can indicate polycystic ovarian syndrome, kind of when looked at in conjunction with other hormones. And sometimes it can also show rare fertility issues such as Turner's syndrome. So that's kind of why we would have that blood test done. Another one that you'll have, and they'll usually give you some kind of named point in your cycle. They may want it done with all of these other tests above, or they might want it done with your progesterone test. It really just kind of depends on your clinic. But it's an indicator for ovarian function. So you might also hear it called estradiol. I can't even say that word. Estradiol? Estradiol. Let's go with that. That'll do. Again, this has a different normal ranges depending on when in your cycle you have it done, and you can see these normal ranges here. It's not commonly used in isolation. It tends to be used with other hormone levels, and it can support and help diagnose a number of different issues, which I won't go into here because it's kind of long and complicated. But just to know that it's something that will probably be tested. And then the key one for me really in my testing was progesterone. Now, progesterone is essentially the hormone that confirms ovulation. So what they're looking for is your progesterone levels will stay kind of reasonably low, you'll ovulate, and then you'll have a spike in your progesterone. So you can see that reflected here. So in the follicular stage, they're looking at levels kind of 5 and below. And then in your luteal phase, they expect it to rise to somewhere between 3.5 and 67. So low levels can show that your ovaries aren't functioning or that you haven't ovulated, and they can also indicate whether you've got enough progesterone in your system to support pregnancy. Because the other issue that some ladies can have is that they don't produce enough progesterone, and therefore they can't support their own pregnancies in that kind of luteal, so post-ovulation stage. So they may get pregnant and then lose that pregnancy early, or they may never even know that they could get pregnant because they just don't have the levels of progesterone and they're not ovulating. So the real biggie for me on this is when you time this test. Now, I'm going to get Nathan to change this for me because I don't necessarily agree with this, and I'll explain why. So we all know that medical professionals love the idea of this beautiful 28-day cycle that we all clearly have. Yes, I can hear you laughing from here. So what they want to do is they want to give you this beautiful idea of you should take this test 7 days before the start of your cycle. However, for me, that would have come up with an accurate result, and I'm not even that irregular. Like, I have a 10-day variability, but I wouldn't class myself as having an irregular cycle. Slightly annoying cycle, maybe, but irregular, no. And I'll explain to you how this would have worked for me, and hopefully that'll give you a good idea of kind of why I don't agree with the timing that they sometimes suggest. In a 28-day cycle, they expect that you have about a 13-day follicular phase where your follicles are kind of growing and maturing, and you're getting one nice big follicle ready to release an egg. You then ovulate somewhere, according to them, around day 13, 14, and then after that, they would expect you to have 14 days of luteal phase, which is the days after you ovulate. All sounds very beautiful and lovely, but doesn't really work in practice with a lot of women. So for me, I have a 24 to 34 day cycle. So I have, like I said, I have a 10-day variability, but on average, take my average, I have about 31 to 32 days. But this meant that I actually tended to ovulate a little bit later, but still not where they would expect me to ovulate either. So I would ovulate in the latter kind of third of my cycle. So I tended to ovulate somewhere around day 20 to 22. And then I tended to have an 11-day luteal phase. I know all of this because I tracked my cycles via body temperature, which I will go into in another video. So if you ladies are interested in learning about how to track your cycles, then bear with me and I'll try and get something up reasonably soon for you. But essentially, because I had 11-day phase after ovulation, if I had gone in 7 days before the start of my cycle for this progesterone test, I would only have ovulated about 4 days beforehand, and therefore my progesterone level wouldn't have been high enough to confirm ovulation. What that means is I could potentially have been put on drugs to help me ovulate that I did not need. So I suggest personally that you track your cycles. You know when you ovulate. You can do this via cycle tracking, like temperature, like I've spoken about. If you don't have polycystic ovarian syndrome, you could potentially use ovulation predictor kits to help you out here, which give like a 12 to 36 hour range of when you will ovulate. I would suggest that you know when you ovulate and then you go 7 days after ovulation, because I think recent research has shown that actually very few ladies have a 14-day luteal phase, and most of us sit somewhere between 10 to 12-day luteal phase, 11 being the most common, which I feel like it means that you would be really prone to being put on medication you do not need. So yeah, that's my little rant about progesterone testing. But anyway, so they will look at your progesterone level, confirm that you're ovulating, hopefully, and then also look to see if there are particularly high levels, which could kind of indicate issues with your glands, with ovarian cysts, some rare cancers, etc. But anyway, so that's that test. And then the final one is they'll test you for a range of infections: HIV, rubella, hepatitis B and C. I think they also did chlamydia for myself and Nathan as well. And those can be done anytime. So they'll either give you a sheet which will put it in with your progesterone test or with your FSH testing. But essentially they'll give you a load of paperwork and you'll probably get 2 sets and say this one should be done around this time and this one should be done around this time of your cycle. So the next one I wanted to quickly touch upon is ultrasounds. Now for me, I didn't have an ultrasound I think until we actually got to the IVF clinic, but potentially they may do an ultrasound at this stage for you. There are 2 types. There's an external scan, but essentially that wouldn't really give them the information they're looking for. So it's unlikely that you would have an external ultrasound, and more likely you would have an internal ultrasound, which is known as a transvaginal scan. Sounds a bit more scary than it is. There is a really small probe which they will cover in basically cover in a condom to keep it sterile, and put a bit of jelly on it, and then that will be inserted into your vagina, and then they will essentially put a bit of pressure on and kind of have a look at your womb, have a look at both of your ovaries, have a look a little bit at your fallopian tubes, and kind of most importantly, they'll have a look at both your ovaries, the number of follicles you've got and the kind of sizes they are, and they'll match that up to where in your cycle you are to see if there's any kind of issues. They might also have a little look at your endometrial lining to see if that matches up with where you are in your cycle. It can be a bit uncomfortable, but the same as a lot of these tests, the more you relax, the easier it is, which is great coming from me, but trust me, I've perfected the art of relaxing for all of these tests. Deep breathing can really help. They will be looking for things like fibroids, blockages, cysts, potentially endometriosis, although I should say here and now that an ultrasound is not a diagnostic tool for endometriosis. And it really bothers me when doctors try and fob people off with an ultrasound test for endometriosis, because it is not diagnostically viable. From there, you will probably have some kind of imaging of your womb and fallopian tubes to check for blockages, because even if they do an ultrasound at this stage, that won't always pick up every problem. I think this is why I never even had one at this point, and I had this done in the IVF clinic, because once you get to the point of going into an IVF clinic for like assisted reproduction, then knowing how your ovaries and follicles are functioning is more important. But this stage, really what they're wanting to look at is whether there's any kind of irregularities in your womb or any blockages in your fallopian tubes. Now, there's a few different tests for this, and they kind of go from least invasive to most invasive. The first 2 are the most common, and then the latter 2 are ones that they will usually use if they pick something up in the first 2 that concerns them, or there's other reasons for them to think that they need a more detailed examination. So the first one is called, this is a bit of a mouthful, so bear with me, a Hysterosalpingo-contrast sonography. I managed to do it, look at me. Which is also known as a HyCoSy, which is a much nicer way and much less scary way of saying it. Essentially, this is an ultrasound, but it's an ultrasound where they inject a fluid into your kind of cervical and womb area. It's a bit intimate in nature because it's obviously involving an internal ultrasound, but it doesn't require any anesthetic or sedation, and there's no exposure to radiation, so it's quite a low risk test to have, which is quite nice. So you have a small tube called catheter inserted into your womb. A fluid then will be inserted in, and then you'll have an ultrasound probe inserted, and they will just record the images of the ultrasound on the screen with the fluid filling the womb space. and looking at the fallopian tubes, and it looks for your blockages. That one is the kind of least invasive, but close by is the Hysterosalpingo-gram, which is what I had done, and I think this is probably one of the more common ones. So, because it gives a slightly more detailed view, but it is under X-ray imaging, so there is some exposure to radiation. So you have to be really certain when you have your Hysterosalpingogram that you're not pregnant. And before you go in for it, they will often take a urine sample and test for pregnancy before they even let you into the room. So just to be aware of that. So it's done in an X-ray department, and it can cause a little bit of discomfort, kind of like period cramping. I have to say, for me, there was some discomfort, but it was momentary. There was a particular point in the procedure where they are blowing up like a balloon in this catheter that's inserted into your womb, and that was the bit that I did find quite uncomfortable. But like I said, it was momentary. I'd go through it again quite happily, and it didn't cause me any bother afterwards either. So what this one is like I said, they'll put a catheter in the same as they would do with the previous test, but then they put in like a contrast dye which shows up on the X-ray, and then it's a similar thing. They take lots of X-rays, and basically they're looking at the images on the screen to see if there's any irregularities in the womb and to see if there's anything that's blocking the fallopian tube. So they'll know this because the dye won't be able to pass into your fallopian tubes. They can also see if there's any temporary spasm which could be causing problems, any kind of distension due to an obstruction, and it's a really good diagnostic tool for the fallopian tubes and the cavity of the womb. So that's probably one of the more common ones you might have. Further on from this is the potential for hysteroscopy. Now this isn't usually done unless you maybe had repeated miscarriages, or one of these other tests has picked up kind of a potential for fibroids, or any other kind of anatomical or genetic issues that mean implantation is struggling to happen. So they might do this in this case. Now, what is it? So a hysteroscopy is essentially where they insert a telescope into your womb to have a detailed look with an actual scope. It's like a camera. So they can get a really good view of your womb and any irregularities in it. It's generally done under local or general anaesthetic. So the good news is you won't be particularly aware of any discomfort during the actual procedure itself, which is good because they do sometimes have to use some forceps or clamps to put to keep the cervix in place. And personally, I've actually had to have that done for a different kind of test during my IVF treatment, and unfortunately it's rather uncomfortable. So the fact that you won't be aware of it is a really nice thing. It's best to not get too anxious about it, because the fact is that you won't feel very much, hopefully, throughout this procedure. What they do is they bring you into a room, they give you some sedation, being that local or general anaesthetic, and then they will open your womb up by kind of filling it with either with gas like carbon dioxide or with fluid, and that opens up your womb and gives them a good way of having a look around the full thing, because otherwise it's a bit squished in there and it's really hard for them to see everything. They'll then insert like the scope into your womb, and the camera will be moved around so that they can see what they're looking at, and they will pick up on any irregularities that were noticed on other tests. They'll have a look for fibroids or any kind of patches that might indicate something like endometriosis, although yet again it's not a diagnostic test for endometriosis, but it can give an indication if there's any kind of areas there that they think could suggest endometriosis. And the only risks that come with this procedure, which are like heavy bleeding and potentially damage to the cervix and womb, and as with most of these tests, there's always a small risk of infection as well. But you pretty much don't have any of these procedures that don't have kind of some of these risks. And the final one I was going to have a chat to you about is the laparoscopy. Now, the laparoscopy is the most invasive procedure, and this will be done under a general anaesthetic. It doesn't require admission to hospital, but it gives the best view of the pelvic organs because essentially a surgeon will make some small incisions, usually in 2 or 3 areas, and then fill your abdominal cavity with carbon dioxide and then put a small telescope in. So essentially this has a look at the entire abdominal cavity rather than just the womb itself, and this is a diagnostic test for endometriosis. But because it's under general anaesthetic and because it's so invasive, it comes with the most risk, which is why it's very rarely actually done. But they will look at the womb, the fallopian tubes, the cervix, by kind of inserting a dye and then looking at the flow through with the scope, the telescope that they put in. And it can be used to diagnose endometriosis, fibroids and cancers. You can usually leave the hospital the same day, so it's usually a day procedure, but you will need to rest for about 48 hours afterwards, and you will have some small scarring, although over time this will mostly disappear. Insertion sites tend to be at the belly button and then usually a couple of ones lower down your abdomen as well. If you go onto our website at www.ineedivf.co.uk, you can see all of this information on our post about it, which we'll put a link to below, and also there's an interesting video there which gives you the pros and cons of laparoscopic surgery. But from kind of the point of view of initial fertility tests for women, this is pretty much it. So this is the kind of test you're most likely to come across initially. There may be other tests that would come up further on in your journey, but this is probably where you would start off. I really hope this was helpful for you. If you have any questions or comments, please do leave them down below. Like I said, I'll try and get a video up on kind of cycle tracking for you all soon. But if you have any questions in the meantime or need any advice on any of these tests, drop us a comment in this video or head over to our website and drop us a comment there, and we'll try and get back to you. If you like this video and found it helpful, subscribe and give us a thumbs up, and we'll see you in the next one. Take care, bye.